the concept of regenerating your natural tissue is the next sort of concept in surgery that's really being at the forefront.
Welcome to VNEW Health, powered by Arms Medical. I'm Robert Greer, and tonight in the studio, we are playing Ask the Expert. We have Dr. Conrad Duncan, world-renowned urogynecologist from the beautiful city of Baltimore, Maryland, back from his trip with his boys from Hawaii. Dr. Duncan, welcome to the program.
Oh, it's good to be here. Good to see you again.
So we've got, we're in social media and we've got the YouTube channel. We've got a lot of followers and we have a lot of listeners and women that will either reach out directly to us with different questions, or they want to get connected with someone like yourself in a different part of the country, or they will type in various questions and hope that we can connect them with some answers that they're struggling with. So tonight, we're going to play Ask the Expert, and I'm happy to have Dr. Duncan in the studio to be able to do that. And so the first question that I've seen a few times is that when medical professionals talk about prolapse, they say it's going to cause pelvic pain. What does that mean? Like, why does prolapse cause pelvic pain? What's going on?
Well, there are a couple of issues right off the bat here. What is the definition of pain? When we talk about pain, we're usually talking about something that's more searing. Generally, though, prolapse symptoms are more of a discomfort. So pressure, bulging feeling, just general malaise of the pelvis. It just doesn't feel right, as opposed to searing pain. So the association between prolapse and actual pain, you have to tweak out what that patient means by pain. It's rare a patient comes in and says, I have a lot of pain from my prolapse. What they say is, I feel awful. I feel like I'm sitting on a ball. I feel like something's falling out. I have a lot of discomfort. And the word discomfort or uncomfortable is more often used than pain.
Right. So it's not that it's a sharp, like when you have a pain in your back, you turn a certain way, sciatica, or, it's not this, maybe it doesn't resonate as that, but it's just this overall discomfort and pain in the fact of making them just feel uncomfortable.
Yeah. And the funny part about it is that there's not a great correlation with the concept of pain and the degree of prolapse. So, for instance, I saw a woman today whose uterus was literally 20 centimeters out of the vagina. So it's a huge distance. Excoriated, meaning that the skin of the vagina was worn out because it had been hanging out. And she was in no pain at all. So the discomfort, of course, I can't push it back in. I'm just uncomfortable. I feel like I'm sitting on a ball all the time, which she was. But the word pain didn't really come out of her. It was more of a description of what was going on, as opposed to, if we were to poke somebody with something or cut somebody, there's a searing pain. So the nerve fibers that carry the sensation of prolapse, the quote unquote unmyelinated C fibers that carry pain, maybe aren't in such great play with prolapse, as opposed to stretching of nerves and just this chronic, unrelenting discomfort. I'm not saying one is worse or better than the other. It's just that you really have to talk to the patient to tweak out what they mean by their symptoms. And when someone says pain, I start thinking other problems: interstitial cystitis, endometriosis, torsion of the ovaries. So you start thinking different things when you hear the word pain.
Right. There's something else that's going on that is giving you that flare, that signal of pain. So you really got to dive into it deeper. And that's really what your pelvic floor specialist like yourself, or someone who is a urologist that did a fellowship in female pelvic floor, they're going to dive deeper and start asking a lot more questions.
And they're going to tweak it out to also always remember that patients can have more than one thing going on. So even a patient coming in with prolapse that complains of true pain that's, intermittent or stabbing, I'm also going to think of other issues that may not be related to the prolapse. So we tend to really have to hear the word pain and find out what the patient needs from it. Some people think, pain is just anything that's not normal. And so we have to find out if that's the patient who's saying pain. When say, well, what is it? How describe that pain? Is it like the pain you've had with a bad period? No, nothing like that. Is it? And if they say it is like that, then again, I start thinking endometriosis. So you really have to tweak out what that particular patient means by the word pain.
Great advice. All right, next question. I'm a 45-year-old active female. My gynecologist fitted me for a pessary today. How long should I expect to use it? And is it forever? Because that was this, we got you fitted, you're going to be better, and treat you and street you.
Pessaries, and especially in younger women, and 45 is very young, it's a great, great topic. We'll start off by saying pessaries are great. They circumvent or avoid surgery. And if they do the trick, meaning what is that trick? Relieving your symptoms. You feel good enough or better. If they do the trick, let's go with it. Problem. The question is, well, how long do I have to use this pessary? If I get it in today and I'm only 45, is this a 40-year experience? And the answer is probably yes. Another caveat. I have this pessary and it's, let's say, my nurse practitioner likes to call them beginner pessaries. It's more like a diaphragm. It's a simple ring. I have that. Can I be sexually active with it? Well, you can manage it. You can be sexually active. You can take it in, put it in yourself. But there are some pessaries which can't be removed by the patient, either because of age or the type of pessary. So they prevent sexual activity. There are pessary management issues, meaning that they cause discharge. They're not the panacea or instant fix without some kind of, no free lunches. So they're not the instant fix that we'd like them to be. Again, remembering sometimes they are the perfect solution, because if you have a woman who's only moderately bothered by a prolapse, she gets a ring pessary. She can take it in, take it out. She only uses it when she plays tennis or runs. Great. This is probably the perfect solution for that patient. But 45, pessary, there's a lifetime management issue now on the table, which isn't, again, a good or bad thing. It's just that it is not something that at 45, you could say, I'm going to have this for 6 months and I'm going to be good. Now, there's a strange phenomenon, which, in 35 years of practice, that we have seen that, and literature doesn't describe this too well, but we've seen pessaries that have been in for a long time, a couple years, and we take them out and the prolapse is improved. We really don't know why, but that can happen. We would never try to sell a pessary as a treatment for a prolapse. It's a treatment for the symptoms of prolapse. But on a rare occasion, we actually see prolapse improve with long-term pessary use. We don't know why, but that does happen on occasion. Short answer, pessary at 45, long-term management issue.
Next question. How do I know if my leakage is stress incontinence or related to my prolapse?
Tough question, because but fairly easy for us to figure out. So what we can do is, first we back up to say you can have stress incontinence, which is the loss of urine with laughing, coughing, increasing your abdominal pressure. You can have that incontinence with or without prolapse. It can be related to the prolapse, but it could be also a very independent issue. It can actually be, stress incontinence could actually be improved by prolapse in some cases. If you have a kinking of the urethra with major prolapse of the bladder, you've kinked off the garden hose and it actually keeps you dry. So we can fix that prolapse and unmask your incontinence. So great question. They are intertwined, but two separate issues. And what we will normally do in the office is to reduce the prolapse when we do testing of your bladder. And one of those things that we fill the bladder up, but we have you laugh and cough. We do that with the prolapse present and by reducing it with an instrument while you're in the office. So sometimes we can figure out how related your incontinence is, your stress incontinence is to your prolapse. And sometimes we'll do intraoperative testing. We'll fix the prolapse, fill your bladder in the OR, in the operating room, and then try to test with what's called a Corday test. How accurate is it in terms of real life? There's debate about that. But we treat them as two separate issues. And the reason that's also important is a patient might come in with significant prolapse and say, well, I don't know, I'm not sure my prolapse is bothering me, but my gynecologist said my prolapse is the cause of my incontinence. And I'll say, would you want me to do a very small procedure to fix your stress incontinence and leave your prolapse alone? Because that's a different beast. That's a whole different type of surgery. And if that patient says, yes, my incontinence is what bothers me, again, I'm going to leave her prolapse alone and just treat her incontinence. So it's important to remember them as two separate, independent issues, even though they may be very intertwined.
Next question. If I keep exercising or lifting for work, will my prolapse get worse?
Probably. Just by the nature of physics, you increase your intra-abdominal pressure. You've got these breaks in the support structure. So you can kind of surmise that that's just going to keep getting worse. No great studies on following patients with different levels of activity, see how their prolapse progresses. There's some sort of level of common sense where we have a patient and we know that patients with chronic constipation, chronic cough, female paratroopers, people who have large insults to the pelvis with pressure of the abdomen have higher rates of prolapse. So it's kind of easy to extrapolate that it's going to get worse over time. Doesn't mean that it's going to get worse enough for us to fix it surgically, but it will get worse over time. Gravity doesn't take vacations. And we don't want people to undermine their own lives or activity to prevent prolapse from happening. That's the one thing that I find is that's why we're here, is to try to say, let's fix things so you can have a normal, productive, high quality of life.
Next question. My doctor told me to just accept it. How do I get a second opinion, and what should I ask?
Well, ironically, your doctor might be right, because the first question is, does your prolapse bother you? And if you say no, then that answer is correct. Then just accept it. If it doesn't bother you and you don't have a mental concept of prolapse being not normal, because that can affect your self-esteem, your sexuality. It doesn't hurt, but I don't like it that it's protruding. I don't like seeing that. My partner doesn't like seeing that. So it's patronizing to tell someone to accept it. What you want to always do is give patients a menu and choices and information so that it's their choice to accept it, not yours. So saying you should accept it means, to me, the only time you would say that to somebody is when they're completely not bothered and don't want to do anything. Then we're mutually accepting that's the condition that she wants to have. Or you might say that to somebody who's an absolute surgical risk nightmare. But even then you have things like Pessaries and physical therapy that you can offer that patient. So that's an answer that should almost never come out of anyone's mouth.
Okay. Next question. If I have surgery, can I still keep my uterus?
Short answer is absolutely. The removal of the uterus has, and I'll say this with a small asterisk, it has nothing to do with prolapse repair. It is not the uterus's fault that it's falling out.
I thought it was the uterus's fault.
Well, that's where the word hysterical comes from. Everything that is wrong with women has to do with the uterus. That's just such garbage, because this tradition of just yanking out the uterus and making things better is something that is so ingrained in medicine for so long that it's embarrassing. So the concept of whether a woman wants to keep her uterus or not should be, again, her decision, and I say almost never part of a prolapse repair. In other words, if you have another way to think about this, you have major league prolapse. The uterus is coming out, the bladder is coming out, the bowels are coming out. You don't hear us talking about taking out your bladder or your bowels. So the concept is, we can fix your prolapse, without taking out the organs that happen to be following that part. So the repair of the prolapse could be better thought of not as a uterine problem or bladder problem or bowel problem, but a vagina problem, meaning the support structures of the vagina have failed, and you happen to have those three different organs following. So removing the uterus, I'll be honest with you, the repair of the prolapse is actually easier for us to leave it in. And the risks of surgery are a little less by leaving it in. So I would say 60% of the major prolapse repairs, when we see the uterus coming out, those patients elect to keep the uterus.
So when would you recommend removing your uterus and having a hysterectomy?
Great question. And I think that, and it's a complicated answer, but I think that the easy answer is if it's the woman's preference. She said, we have to support the entire spectrum. There are women who have had their kids and like, get this thing out of me. And there are women who are like, this is part of my womanhood, part of my body. I'm keeping it forever. And you have to respect the spectrum. So the first thing we do is get the patient's input. The second time that I would professionally and surgically recommend it is if I've had a failure of the apex, that's where the uterus is, the top. If I've had a failure of the apex in someone who's had a hysterectomy or kept the uterus for the first time around, and don't let a surgeon ever tell you that she or he has no failures. That would be a lie. So that apical failures do occur. And if I had a patient who kept the uterus and that failed, I would, it's the caveat of doing the same thing twice and looking for different results. That person, I would recommend we do the hysterectomy if they want to have another surgical repair. There's not great evidence to support that recommendation, but for me personally, that's what I would say. The other time that I would recommend, and this is where it gets a little complicated, is that insurance companies play a strong role sometimes in what we do. And that's just the reality of the landscape. If a patient desires to have their ovaries removed, sister with ovarian cancer, or has a real fear of developing ovarian cancer, in that postmenopausal woman, doing the hysterectomy or removing the uterus enables us also to remove the ovaries. So there's that complicated part of this that's tricky. It dances around some insurance issues and some surgical issues, but removal of the uterus is an acceptable part of prolapse repair of the apex. Removal of the ovaries in a postmenopausal woman, one woman who's past menopause, is also an accepted part of the hysterectomy. So you can see that if a woman comes and says, I just had an auntie die of ovarian cancer, it was horrible, and I'm 58 or 62, you're doing this prolapse repair for my uterus coming out, take out my uterus, and more importantly, remove my ovaries. So there's a little bit of a complex part of that rarely gets discussed. Certainly isn't in the books, in the text, or on the internet, but it's one of those things where your doctor should kind of bring that issue up.
As well as the fallopian tubes.
Yes, absolutely. Fallopian tubes come out, and then that's a great point, is that the fallopian tubes would come out or be recommended to be removed if we're doing a hysterectomy in a younger woman, premenopausal or perimenopausal, around the time of menopause. That person will have the tubes removed because some ovarian cancers do start in the tubes. So, and they aren't doing much. Again, if one wants to keep them because they're part of her identity, they should be left behind. But in the normal circumstances, we would take out the fallopian tubes whenever we're doing a hysterectomy.
Next question. Thank you for that, Dr. Duncan. Is that painful intercourse? Right now, my intercourse is painful. Will having surgery help fix that?
Whoa. So the fancy word for painful intercourse is something called dyspareunia. So if you hear that term, that's what that means. And the sort of the smart aleck answer to that question is it'll help your painful intercourse if your painful intercourse is being caused by your prolapse. Now, it sounds smart alecky, but it really it sort of underscores the fact.
Peel it back to say we got to make sure if you're saying that you have dyspareunia, is it due to your prolapse.
Right. Exactly.
Are they connected?
They can be, and they, but they might not be. Dyspareunia could be anything from fibromyalgia. There are all sorts of reasons why a woman might have painful intercourse. That workup is going to be independent of her prolapse. We almost never blame the prolapse for dyspareunia because you'll often miss other reasons. Now, that being said, it's very difficult to do sexual questionnaires that are meaningful in prolapse patients. There are validated questionnaires. This research is well documented, but it's very difficult to get a great sexual history on someone who's got major prolapse because that affects the woman's sensation as well as her mental identity of her own sexuality. So when you have a woman who's having painful intercourse, a major prolapse, you can sort of say, well, we would expect improvement in your horizon, if that makes sense. We're going to restore the vagina to like it was before you ever had prolapse, before you ever had children, and let's move forward from there. So we like to kind of package this as not a cure for dyspareunia, unless it's directly related to the prolapse, but as a restart, a restart to the vagina so that your sexuality can sort of begin from there.
Let's get you anatomically corrected, and then we can address maybe the other issues that are presenting, or maybe this will actually take care of it.
Yeah, but you never sell that as, you never sell snake oil. So you rarely want to say to patients, I bet you I can fix your dyspareunia by putting your prolapse back together, putting it up. So
don't connect them.
Yeah, don't connect them.
There's underlying things that could be happening that we have to take it one step at a time.
And there's always the surgical caveat that you restore the function. No, you restore the form, you restore the function. So that holds true generally in accident, holds true across all surgical lines.
Okay. Next question. Is mesh safe? What about biologics like VNEW? Because they haven't heard of it, and they, haven't heard of our little company, Arms Medical. Is what we're doing safe, and is mesh safe because of all of the things that they've heard and read about and seen on television?
That's an hours long conversation, but we'll do it in 5 minutes.
Try to
try to wrap it up. The mesh controversy, almost everybody's heard about it. It was the concept that prolapse means there's some weakenings or breaks in the support structures, and if you have that, you need to augment or support it. And it's actually a great idea. It works for any hernia you have. They're going to put mesh in there. It does work. The problem is it's a foreign body that's there forever. And the vagina is a very dynamic organ. We found that its erosion rates, its pain, it's everything that I could tell you about mesh. It was a bad idea to put it in the vagina. And that's why the FDA said no more. Many countries have banned it for the use for incontinence repair, in addition to prolapse repair. I don't, the time that it took to get it off the market from putting it in the vagina, when everybody woke up one day and said, that's a very bad idea. It took a long time. It took a lot of women's voices to say, we're being assaulted by this product. Whether you believe it's a long-term a long-term inflammatory condition, undergoing biodegradation, I can make plenty of recommendations to where to go to render your own opinion about that. Because my opinion is based on some science, based on what I've seen over 35 years. And I've put a lot of mesh in women, and I don't anymore. But I saw all the complications, and I knew well before the FDA announced that it was not uncommon to have major complications for mesh. Now, we stopped 15 years ago using it because we saw, and there was one year I put more mesh in women than all but a couple of people in the country.
You did a very fast reset based on your volume and being one of the highest surgical urogynecologists in the country. And your patients coming back to you, you could immediately see, I think I got to find a better way.
Right. And there's a wisdom of that, maybe all your complications go see other people. And that's that's a problem that you have. But in the urogyne community, if you had a problem from a patient, you'd ask that patient, "Can I call you another doctor?" and let them know. And so we saw these mesh complications arise fairly quickly, not in a vast majority of patients, but in enough to say, "Whoa, these are some bad complications." So finding another way to augment, because the augmentation or the support or the necessary help that the tissue in the pelvis might require, that concept never went away. The concept then became, how do we get something in there that's closer to natural, that's not a foreign body that the woman's body will be reacting against for the rest of her life, but yet do the trick, meaning help, support. And that's where the concept of regenerative medicine comes in. If I can snap my finger and make a patient, whether it's a man or woman, a hernia, vaginal wall prolapse, create their own new fascia or support tissue, that's what I like to do. And so regenerative medicine, I like to kind of think of it as the next level of medical wisdom. So like AI is to the internet, the concept of regenerating your natural tissue is the next sort of concept in surgery that's really being at the forefront. So the concept there is to say, I'm going to use the same surgical principles that we've been using for 50, 100 years. Some of the things that we do to fix prolapse are older than I am, even, that we want to conceptually get some sutures up here north, use those as pulleys to get things up, and then somehow create some scaffolding that makes a new vagina that's being supported. Whether that scaffolding is the patient's own tissue, whether it's plastic mesh, whether it's a biomaterial that help produce constructive remodeling. Those are fancy words for basically tissue engineering, that I want to make you make your own new tissue. However we do it, the concept is the same. It's the physics and the surgical techniques are the same. The use of biomaterials that create regenerative medicine it's an absolute godsend in the sense of what it's done for us in pelvic surgery. So what I will do is take a piece of cadaveric dermis, which is the protein left behind after processing, place it in. The body recognizes it as, what am I supposed to be here? I'm supposed to be fascia. And it replaces it over time with your own body's material, and it's gone. After a certain amount of time, it will be gone and replaced by your own tissue. Is it perfect? No. No surgery that we do is perfect. There are failures every way we do these things. But our failure rates are very small, and the end result yields a very natural, supple, mobile, pliable vagina that's actually put back in the right place. So that's my sort of 5-minute dissertation on augmentation, mesh, natural tissue, and our new sort of level of bioengineering that we're utilizing now. And I've been using that for over 15 years, whether it's my slings or my prolapse repairs, and we have had fabulous results. So part of this is based on evidence, and part of it's based on clinical experience and clinical acumen.
Okay, thank you for that. Next question. My doctor said that they were using native tissue to help repair my prolapse. What does that mean?
Native tissue is a term that means the patient's own tissue, native to them, not native to another person. There are different types of grafts. There's xenografts, we have different medical terms for different types of grafts or tissue we might use. But your own tissue is what we call native tissue. And that grafting can be done one of two ways. I can harvest some tissue from you, like from your belly or from the side of your leg, some fascia, and use that, which is great. But the problem is that we have to get a pretty big sheet from somewhere that you really don't have a donor spot for that. Because we take it out, then that whatever donor spot that we took it from is now lacking that material, right? You're robbing Paul to pay Peter. So the issue is, we like, our ideal world we take some of your stem cells and we grow you a big piece of fascia in the lab and use that for you. That technology is not readily available and cost effective right now. So we have to go look at the next best thing. Here's the problem with native tissue is, are we going to get enough of it to create that entire new scaffolding for the vagina? Difficult to do. Let's say I use just the tissue in your vagina to fix you. Part of the problem is that though that tissue has shown basically separation from some of its own support structures, so I'm going to have to suture that back up and then use what I can. And we find that there's just not enough. There's not enough to create an entire new vagina. And there's probably the element of common sense that if your tissue has failed you already, just putting it back up doesn't mean it's not going to fail you again. So, and this is one of the areas, big areas of research that has been sort of left unfinished in urogynecology, is how well do these native tissue repairs do when done exactly the same as a bioengineered material. And these are big holes in our research, and we're using sort of numbers and clinical data that are based on individual surgeons, which really isn't the way we like to do things. So native tissue repairs have been done for forever, and unfortunately, they have a huge failure rate. And the failure rate for native tissue repairs is why we went to using the mesh. So we noticed that native tissue repairs gave us a very unacceptable failure rate, recurrence rate, and hence, let's try the mesh, which actually worked. The problem is the mesh had a whole host of associated complications just linked to the mesh, not just to the surgery, but to the mesh itself. So we recognized that that wasn't a very good procedure. Hence, we came up with the mesh, and now we have to figure out what are we going to do instead of plastic mesh.
All right. Thank you for that. All right. Final question. Talking about recovery. What is it? I've heard, this is a woman that's asking this question, is heard anything from, 2 weeks to 3 months to, can't lift anything heavy to don't lift anything heavy ever again. Right. It's like this huge spectrum. What can I expect after my surgical, going into surgery and having prolapse, remedied?
And that's a great question. The issue is that the first question we have is, what are you trying to recover to do, right? Are you recovering to deliver packages for FedEx over Christmas versus are you trying to recover to go sit at a desk? So that's the first caveat. And the second was, how important is it for you to get back to work? If the world doesn't run without you there, that's a different recovery period than for someone who's like, I've got 12 weeks of federal use or lose and it's October, right? So the answer to that recovery question is going to be somewhat based on the patient's needs to get back to what job. Your family doesn't eat unless you work. You're going to go back to work sooner. Now, that also undermines the fact that most of the recovery wisdom that we have on what to do and what not to do is completely made up. We don't know. We just don't know. We don't have great studies to say this group needs to go out and train for the Olympic powerlifting at 2 weeks versus this group that's going to lay flat for 6 weeks. Some of the work has been done, and we find out that, ironically, getting up out of a chair is one of the most intense things you can do in terms of pressure to the vagina.
Right.
And so
get out of a car,
yeah,
out of a chair, right?
get up with your hands. So even the things that we think might be bad for you to do, like bending over to lift something, may not be so bad. That being said, what we normally will tell patients after major prolapse repairs, you do have to give the pelvis some rest. You can't start pushing on my repair with increasing pressure right away and expect it to do as well as somebody that's laying flat. Now, so we have to do this balance. We don't want people to lay flat. That's not healthy either. So we just simply say, for 2 weeks, let's lay low, and you'll be 80% of yourself in 2 weeks. Now, again, what does that mean? 80% of a FedEx delivery person? No. 80% of someone who's got to go to the office? Yes. Most people are driving after 2 weeks. You're not ready for sexual activity for 6 to 8 weeks. And that's a real number after major prolapse repair. That doesn't mean you're hobbling for 6 to 8 weeks. It means that the vagina isn't healed enough for sexual activity because there's some suture lines and they need time to heal. So, and the healing process is there's a differential based on individual patients who will simply, some people just recover faster than others. And so most of that stuff is just made up that we tell you. Some of it is built around common sense, and some of it's built around just tradition. We tell you to do the XYZ. If you're not do XYZ, it's because that's what we learned in residency or fellowship. And so we have to be cautious, but not ridiculous. We have to be evidence-based and common sense-based on what to tell patients. And so let's go with the patient who has no complications and a standard major prolapse repair transvaginal. Again, just to emphasize, 2 weeks, you're back to 80% of yourself. It is major surgery. There is generally some discomfort in the back for a little bit and some vaginal discomfort. But I like to use the gauge of most patients go home without narcotic medication and do not use narcotic medication pain. Of course, some of that's based on the fact everybody wants to stay away from narcotics usually, but
I give you that level of what the pain scale looks like, and that you might have some discomfort, and you're going to need to take it easy. And, my mom had the surgery here a few weeks ago, and after about 3-4 days, I had to put her in timeout because she wanted to do too much. She felt amazing. Her prolapse was repaired. It was, put back in its correct position, and, put the Swifter down, Mom.
Yeah, and that's often the case where Sandra, my nurse practitioner, has to tell patients, you were out at the mall, it's only been a week. That is very often the case. But we don't try to also sell that as like, you're going to be perfectly fine in a week. We say, take 4 to 6 off to your 80% reassess. And if you want to go sit at the office because the World Bank doesn't run unless you're in the office, you're going to go back to sitting down in the office in 2 weeks or work from home in 2 weeks. But if you've got to deliver packages for FedEx at Christmas, you need 8 weeks
to do it at that scale.
Yes, absolutely. And not because of pain, but just because we want our surgery to heal before you maximize the push.
Got a lot of sutures. We want them to be able to, start to heal and not go back to where you started from.
Yes, exactly.
We're going to close out at that from a recovery section. Of course, Dr. Duncan, always a pleasure to have you on the program. I'm sure that the ladies that are going to like and subscribe to the VNEW Health Podcast and hopefully type in their questions. We're going to have some new questions for the next time I have you on the program. Ask the Expert with Dr. Conrad Duncan. Thanks for joining.
No, thanks for having me. And the questions were great. And we look forward to more questions feeding off the ones we answered. If the answers weren't good enough, let me know and we can dive deeper into any one of those. Any one of those topics is an hour of discussion. So,
very, very, very well. Yep, okay. Absolutely. And thank you again.
Thanks. Appreciate you.